This is Alissa.
And this is Caroline. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We are proud medical surgical nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey. Evie and Chelsea could not join us. Alissa is here with me. And so let's have a quick catch up, Alissa. What's been going on in your neck of the woods since that last time we were together?
Yeah, it's so great to see you, Caroline. I'm glad we got to do this together. A couple things. One, you might already know because I put it up on my Facebook, but I am now a published author. So excited about that. So grateful to AMSN for supporting the work that I do. But one of the other things that I have been doing is vocal therapy. I don't know if the listeners have noticed the last one I recorded when we were at convention, I was really straining to get noise out while I was talking. So I have been in vocal PT, I guess. I don't know what else to call it. And also cough therapy because I've always had this like chronic cough and finally I'm taking care of myself, which we don't take good care of ourselves.
Wow. I didn't know that was a thing, but voice sounds stronger. It didn't sound bad before.
I had to relearn how to talk. It was weird.
About that.
Yeah, very strange. So what about you, Caroline? What have you been up to?
Today was traumatic for the first time in many years. I had to have not one, but 3 fillings at the dentist. And dentists are just not the most favorite place in the world for me.
No, that's terrible.
And they weren't even bothering me, but the dentist said there's some hairline cracks and it'd probably best to take care of them now. I'm like, no, it's because it's the end of the year and I have good insurance. That's why you want to do this. But
oh my gosh, you're probably right.
It's just totally draining laying there with your mouth open for an hour while they come at you with all those implements. I've never been a fan of the dentist. I think it goes back to watching Marathon Man years ago. Anyway.
It is awful. Glad you survived.
Yes, and now I can speak now. Earlier, we would not have had a fun conversation with me drooling out of the side of my mouth. Anyway, what else? So one semester closer to graduation for my youngest daughter, and 120 days to my older daughter's wedding. So,
that's exciting.
Lots of activity there as well.
Yeah.
So, and of course, busy at work, always. And of course, the hot topic is the vaccine mandate, of course, and that's causing a few bumps in the road. But what are you going to do? I'm
going to roll with it. That's what I'm doing.
That's exactly it. That really is it. Yeah. Yeah.
Absolutely.
So what shall we talk about officially today? How about we talk about post-op assessment 101?
That sounds delightful.
Sounds like a plan?
It sounds like a great plan.
So what would our listeners need to know about the post-op assessment? What do you think?
Well, we have the standards. Hopefully they're the standards that every nurse is taught with your post-op assessment, making sure that you're doing your routine vital signs. They're, of course, much more frequent when a patient is coming out of surgery. So when they're in PACU, they're much more frequent. And then when they are put out on the floor, at least I know in my hospital, we do vital signs every 30 minutes for the first 2 hours. And then I believe it goes every 1 hour for 4 hours. And then it goes every 4 hours or something like that. I'd have to double check it, but we have
Yep.
Did I do it right? I think I did.
Yeah, that's how we do it. And that's what our AMSN core curriculum supports. So I think we're all on the same page there.
Oh, good. Yes. Okay. So memory serves correctly and it's in alignment. Excellent. So of course, there's much closer monitoring that we're doing right with their vital signs. And that feels pretty standard that we should be doing. And then there's always that assessment point. One of the things that I find interesting about post-op assessments from where I came from, right, the units I worked on, there's always 2 lines of thought: a focused assessment just on the surgical area and a complete assessment, a complete head to toe.
Right.
What are your thoughts, Caroline?
First of all, that transition from PACU to the floor is always important. There's always the rules that have to happen, but never quite happen consistently. I always tell the tale about the report that you get from the PACU nurses, talking about walking a mile kind of thing. The report from the PACU nurse, the patient's awake, alert, and oriented, their pain's under control, will be right there. And before you turn around, there they are, wheeling the patient down the hallway. you kind of look at them and you think that chest isn't rising like it should be. So that focused assessment, first of all, should look at the basics of airway, breathing, and circulation. And there's a line that I've always used, less than 8 intubate. And there's been many a time when I've had a patient arrive back on the floor and they have not met the criteria in the PACU because it's the busiest day of the week in the OR and they're churning the patients out and they've got to move them to the floor. So I think that's one of the messages to get across to our listeners is never be afraid to say this patient doesn't meet our criteria. And for the safety of the patient and for the best patient outcome, you have to meet criteria. A lot
Absolutely.
of them, PACU nurses use that modified Aldrete score, and they have to meet that criteria before they leave PACU. So let's say they meet all that, they come to the floor, that focus assessment, what procedure was done. That's the first thing I would always look at. Look at the dressing. Is it dry, intact? Is there a drain? Is the drain connected? Is the suction on? And of course, is the patient awake, alert, and oriented? And are they pain-free? And usually that's a little bit groggy, so they're not entirely out of the woods. And then start for head to toe. And don't forget to have a conversation with your support team, whether it's your patient care technician or CNA, about the importance of vital signs and what to report back to the nurse during those initial crucial 4 hours back on the floor. Those 4 hours and extend into 8 hours. But I think that's a very important takeaway. Definitely.
It's funny how you mentioned make sure your patient meets criteria to even come out of the PACU. It reminds me of a time when I was charging the unit and a nurse had come up to me and told me that her patient had just arrived from the PACU and the report that she had received did not really match the patient that came, because in report, she had been told that the patient was doing fine on a nasal cannula, maintaining their airway. Everything's great. Patient comes up and has a nasal trumpet in. And they're like, if you just leave it in, the patient's fine. Just leave the nasal trumpet. And I'm sorry, but that's not something that we play with on our unit in acute care on a med surg floor. And there was some like shock and like, what? So I think great point.
Funny, right? Yeah.
Yeah. Funny now. I can laugh about it now. At the time, we were nervous because we didn't want to lose the patient's airway.
Yes.
Yeah. So I think that is a very important tip on making sure the patient meets criteria to come to your unit in the first place. We've had a lot of instances where not quite understanding what the plan was for the patient. And so you get a phone call from the OR because for whatever reason, and usually it's vascular surgeries, right? Going in through femoral arteries and doing that kind of stuff where they just want the patient to recover in the room. But a med surg nurse isn't trained to do that kind of recovery at the bedside. So wanting to make sure that we have the skills that we need to do the proper recovery for the patient once they hit the unit is really important. So I think that you had some very valuable first starts.
Absolutely. The other thing to think about is the importance of assessing fluid balance. Oftentimes in the OR, of course, the surgeon wants that patient to keep their fluid volume up so that they can maintain a healthy blood pressure. If they're diabetic, they don't want them bottoming out. So it's important to review the IV fluids that are hanging. And remember that our normal salines of the world, our good isotonic fluids will kind of keep everything trucking along. But oftentimes coming out of the OR, they are going to have a hypertonic dextrose-based fluid hanging to pull fluid off of the tissue. A lot of times in the OR, what happens behind the red line kind of stays behind the red line until they third space or go into fluid overload. And so that hypertonic solution is really important. So we want to make sure we've got the correct solution hanging and that we don't keep that hanging forever and ever, 1 or 2 liters. And then the nurse should be looking for an order to stop that or asking the doctor for an order to stop that. So intake and output, very important. And of course, then that connects to that head to toe assessment with the pulmonary assessment, making sure that there's not any signs of fluid overload there as well.
I would also state that the more you're taking care of post-op patients, the more you'll become familiar with what you'll see as a trend or an expectation.
Yes.
One of the things that I learned is when I took care of young, healthy patients, those patients really did diurese all those fluids quite quickly when they came to the floor. And so that's something that I came to expect. I would know this, okay, you're young, you're healthy, you're going to diurese overnight or in the morning. And so when my patients didn't do that, that actually spoke to me. And that was like, hey,
yes,
you're young and healthy. Why aren't you diuresing now? Do I need to worry about like an acute kidney injury or?
Yes.
And I remember having those conversations. There was actually one very specific time that I went up to the resident because I'm in an academic medical center. So I've got nighttime residents everywhere. Went up to a resident at night and I said, hey, Mr. Smith in whatever room, he has not started urinating. He's not diuresing. It's 2 a.m. Should we start some fluids? And he was like, are you concerned about this? And he looked at me like I was the biggest idiot in the room. And I was like, yeah, I am. And he's like, I'm not even concerned. And I said, okay, cool. We'll see how his labs fare out in the morning, because I was incredibly confident that I was right and he was wrong. And 6 a.m. labs started and the day shift doctors came in and they're like, no, this guy's in acute kidney injury. We need to get some orders popped up for fluids. And I grabbed him and walked past the night resident. I'm like, how weird, he needs fluids.
See, you got to love stories like that, because how many times in the initial postoperative environment have nurses saved the doctor's butts? Let's be honest about this.
Absolutely.
And
that's why we're here.
Dehydration is always something to consider, because preoperatively, patients kind of go to the extreme sometimes with the MPO situation and give up food and drink, way ahead of time sometimes. And I've seen that happen along the way. And they're so volume depleted that they're not making that baseline 30 mLs of urine an hour. And then you're having to look to rehydrate them postoperatively. So
exactly.
Fluid balance, for many years I worked renal, and so it's almost been traumatized by it. But, intake and output and daily weight, that's what we learn. And it can save a lot of complications from occurring. Let's talk about pain management.
Big hot topic.
What are your experiences with that? You don't want to snow the patient. Obviously, you want them to be awake and able to get up and start ambulating, because that's another important thing. And of course, there are some doctors that will only give medicine X or only give medicine Y, and you don't call them for any other orders. What are your thoughts on that?
For me, pain management is difficult because I was raised in the era where pain's the fifth vital sign, and you just treat the pain, and patients have less than a 1% chance of getting addicted to their medications and all that kind of stuff, which we all know is crap now. So my opinions on it now are very different, because I felt like when I was at the bedside, I was a part of the problem unknowingly, spouting off bad statistics and bad literature, just like everybody else. I still believe that there is a place for pain management, because we do know that we are able to perform in our physical therapies and we can relax more and allow that healing process when our pain is well managed. I just think that it's really important that pain management is for pain management. And our goal really is always to wean off that medication, that we're finding the medication that manages the pain. It's not as easy to me as it used to be. You know, it used to be like everybody gets 15 milligrams of oxycodone and everybody gets 650 of Tylenol. And you know what I mean? It was like a buffet of pain medication. And now,
man, we used to have a surgeon going back many, many years now, an orthopedic surgeon, and it would be IV for the first 8 hours. And then you would transition to an oral narcotic, and then you would move on to the Tylenols at the time. But you're right. That's a very good thing to consider. We are living in different times now, and that feeling, that high, that buzz that people get. I think the message to get out there is the fact that we really expect a lot more of our patients now. I mean, for a med-surg nurse to even talk about a post-op patient for more than 2 or 3 nights is a rare occurrence. And we expect our patients to be up and out of the bed and doing their incentive spirometers and achieving all these goals in less than 24 hours. And so the only way you're getting me out of a bed if I've got an incision somewhere is to make sure, first of all, that I'm comfortable in doing so. So I think, as always, the message is individualized pain care to meet the needs of the pain level that the patient voices, knowing, of course, what the patient says it is. That's what we go with.
And it's challenging, right? Because you have other countries in the world that don't manage pain as the way that we do. Right.
Well,
and so
it brings in a moment about culturally diverse care. And in some societies, I'm going to use a British example, we're stoic and we have that stiff upper lip and we don't take any pain medicine. No, not really. But it's that misconception sometimes. And then other cultures, it seems to be a sign of weakness if you accept pain medicine. But it hurts, surgical incisions hurt. Gas
Surgery
hurts.
Yes.
Let's have a conversation about that post-operatively.
Well, and, I worked with a lot of surgeons that would go into like third world countries and offer these surgeries and huts and all that kind of stuff. And they give them Tylenol. Recovering from a surgery with a Tylenol and an orthopedic surgery with Tylenol seems like
I don't think
mean. So. It seems mean to me, but when you hear these surgeons talking about it and then complaining, or contrasting, I should say, the pain management that we do here, it makes me wonder how much of that is cultural, how much of that is our expectation that I should not have to experience pain versus if I lived somewhere else and I didn't know anything different. And so I would be forced to. I always find that kind of argument interesting when it comes to pain management, because knowing that it's done differently in other countries across the world, knowing that the United States is like 80% of the consumer of narcotics across the entire world with only like 25% of the patients. I think that's the statistic. I think I'm quoting it correctly. But, knowing that that's what it is, it does make me feel concerned that maybe we aren't doing it right. Or
and that's where you can learn from patients and if they are born in another country and what their attitude is or their beliefs or why they are led to think the way that they do. And it probably dates back to what they saw from their parents and older family members. But, the bottom line is they've got to be comfortable. That's what's the most important. And aside from the incision, as I just said, let's talk about post-operative flatus or the accumulation of gas. Let's just say it like it is. It can be extremely painful. And there's a wonderful teaching moment to be had when anyone goes home, especially if they've had anything laparoscopic. This too shall pass, as the expression goes. And of course, the only way to do that is time and ambulation.
Oh, ambulation is so important.
Oh, absolutely. And if we don't get that message across to the patient, they're going to go home and sit in that recliner and not be up and moving around. And then there are potential for other complications there as well. So that kind of leads me into something that I'm not as knowledgeable as I should be, but I feel like our listeners will want to say this out loud. And a lot of facilities now are introducing something called ERAS, the Enhanced Surgical Recovery. Comes down to many factors, one of which is perioperative temperature management. The other thing is feeding the patient sooner rather than later to actually get the gut to work, and so therefore help the air move on out. Very different concept to back in my day where we would listen so attentively for those bowel sounds. Now we're like, get up, get moving, pass that gas, keep the temperature within a certain range, assess for infection a whole lot earlier, be aware of how much intraoperative blood loss occurred as well. So if it's something that your facility does, you're right on track. The enhanced surgical recovery is definitely the best evidence-based tool to use to get patients up and moving around and discharged in a timely fashion with minimal complications.
So an interesting story about that, and hopefully my husband doesn't care that I tell his stories, but here we go. Last year in 2020, my husband and his twin both had to go in for a lumbar spinal fusion. Okay. Both got hardware put in. Different times within about 6 weeks of each other. My husband obviously is married to a nurse. We live here in Utah, and ortho is my bread and butter. That is what I did at the bedside. I did spine patients all day, all night. Unfortunately, my husband's twin lives in Arizona, not married to a nurse, and was discharged and sat in his recliner for 3 weeks because he was babying his injury and did not know that ambulating was going to be his best friend for that kind of a surgery.
Right.
My husband was ambulating that night in the hospital because I told him, if you can't sleep, just get up and walk.
Yes.
I'm like, if you're don't just lay in bed. If you can't sleep, get up and walk. That'll help you. So he walked so much in his one overnight stay. They discharged him on post-op day 1 because he had gotten up, he had walked, he peed, he had hit all the boxes.
The model patient, we love them. Yeah.
Yes. Yeah. And he continues to blow his doctor away after more than a year. His x-rays look amazing. He has no residual pain, no residual numbness or tingling in his leg, all that kind of stuff. And unfortunately, my brother-in-law still struggles with pain. So I think that right there can just give you a contrast on how important it is that your post-op recovery, like you do all the steps that you need to for ultimate healing and recovery.
And that falls beautifully into the enhanced surgical recovery when we look at early post-op mobilization, early removal of tubes and drains, early transition to PO meds, and earlier food. And who doesn't love that? It's the first thing patients ask, is it not? When am I going to be able to eat? Ultimately, we've got those better patient outcomes. Satisfaction scores will go through the roof because the patient doesn't have to stay in the hospital a minute longer than they want to.
Exactly.
It's a much better use of resources. So that's a great story to tie into the evidence behind that. Yeah.
It's always fun when you have like a personal story that supports the evidence.
Definitely.
I feel horrible that my brother-in-law had that experience and that we were unable to influence his journey the way I was able to influence my husband's journey. But as an outsider, just as a third party kind of looking and comparing how it ultimately went, I found it really interesting. And they're twins, right?
Yes, that's incredible. So we talked about young, healthy patients and thinking that the postoperative assessment is not as important. And the importance of ambulation. And many years ago now, but I remember we discharged a patient with laparoscopic removal of something, I'm not really sure. And he essentially went home and sat in his chair or in his bed for those first 48 hours postoperatively through a clot, developed a DVT, which detached, of course, and through a PE. And of course, the worst possible outcome you can imagine happened in an otherwise healthy young adult.
That's terrible.
It sounds basic, it sounds fundamental, but you've got a story with a great outcome, and there's always a story with a not so great outcome. So it's just absolutely essential that ambulation is a part of the package.
Absolutely.
With all of that discharge teaching.
So many reasons, right? Not just for, blood circulation, but also if they don't like doing their IS, get them up and moving. You'll get that air flowing, get the lungs circulating. There's a lot of reasons why ambulation can help them. Blood flow, blood circulation, helping with those lungs and helping move that gas. So there's a lot of reasons why we want our patients to get up and walk after surgery.
For sure. And then we should focus perhaps for a minute or two about special populations post-operatively, specifically older adults. And there's the core curriculum classifies a young old adult between the ages of 65 and 74, and then an old adult, I guess, between the ages of 75 and 90. And then God bless them, they're very old, who are over the age of 90. So they're up there. They're up there. I think that the message for our listeners is that those assessments need to be perhaps a little sharper, looking at cardiovascular changes, respiratory changes, GI changes. Everything kind of slows down, can become a little more sluggish and not as robust, of course. Doesn't mean to say there's anything wrong. They're just seasoned. They're a little mature.
Well, in that patient, I'm not going to expect a diurese on their post-op day 0, right?
Yes,
this patient's going to take, and I'm not going to worry about an acute kidney injury on this patient right away. I'm going to give them some time.
The other thing is the comorbids that go along with that, like osteoarthritis. The longer somebody lays still down on the OR on the table, it's going to take them a few more minutes to get up and moving around. And so that needs to be taken into consideration as well.
Well, and the other thing is thinking of positioning on an OR table. So a lot of times for patients, especially patients who had posterior back surgery, they're positioned on their stomach. So that a lot of pressure is on that chest. And they complain about tenderness or soreness when they're breathing. And it's because they were laying on their rib cage for a couple of hours, not comfortable. So just understanding where these pains or where these complaints could be coming from and which ones we need to be concerned about and which ones make sense. Like, yeah, you're laying on your rib cage for about 3 hours in surgery, so that's going to be tender.
And the other thing to tag on to that is because we discharge our patients more quickly, that it might take 2, 3, 4 days for aches and pains and bruises sometimes to come out, depending on the position that they were in. And so that should be part of that post-op discharge teaching, because as surgical incision pain declines, muscular problems might come into play depending on how long they were positioned, depending on what surgery they had.
Mm-hmm. And when we are talking about those special populations, especially when we're getting into our older, I don't remember.
Older, yes.
Older, right?
Yes.
Thinner skin, less muscle mass, less tissue mass. So they really are more prone for those tissue injuries, pressure injuries, deep tissue injuries, all of those things coming out of the OR. So definitely want to be aware of those possibilities and assess for them. They're also prone to those device injuries, right? They can get the pressure injuries from their oxygen tubing across their face or their ears or in their nostrils, pressure injuries from a catheter tubing, pressing against their inner thigh, or, you know what I mean? These patients are pretty vulnerable to skin injuries. So we need to watch.
You mentioned catheters, and that triggers a thought there, of course. A lot of facilities out there now, organizations have nurse-driven protocols to get those indwelling catheters removed within 48 hours. We have very specific criteria nowadays for keeping a Foley catheter, an indwelling catheter in the bladder. And so that's a good reminder for our med surg nurses there in this environment that catheter needs to be out as soon as possible to fall in line with Joint Commission standards about decreasing the risk of infection by way of catheter-associated UTIs.
Exactly.
So that's a good thought as well. The same with wounds, of course, assessing wounds so that we decrease the risk of surgical site infection, another Joint Commission goal.
Absolutely.
And so safety comes into play there as well.
Yeah. So it's very important to understand what the expectations are for the surgical site and the assessments, and whether or not you're removing sterile dressings or whether or not sterile dressings have to be kept in place for a certain amount of time. So really important for you to be familiar with the surgery that you are working with your patient and the expectations for that follow-up wound care, whether or not you need to be involved in that, because we do want to make sure that we are not having surgical site infections.
Right. So our time is coming to an end. So let's do a recap and see if we covered everything. So admission from the PACU and vital signs, you covered that. Your memory was excellent there.
Lucky for me.
And then those first 8 hours, looking at vitals, looking at urine output, the focused assessment, expanding to the full body assessment. And then after the first 24 hours, just continuation of that and anticipating discharge sooner rather than later. Wound assessment, we touched on that.
Ambulation.
Ambulation, and those all important post-op discharge instructions. If wound care, if there's a drain involved, the patient needs to be taught how to empty the drain. And again, importance of ambulation. We didn't even talk about TED hose, but I think we that goes with the territory and the ambulation to be up and moving around. As always, our time always runs away from us, but hopefully that was a good recap for everyone, and we hit the high points there.
I sure hope so.
Is there anything else you can think of?
We also touched on pain management, which is much more challenging to me now than it used to be, but to a brand new nurse, probably pain management isn't nearly as challenging. I think for me, it's just the era in which I was raised as a nurse.
Sure. Yeah. I think that's a very important point to mention, though. I kind of forgot about that, but you're absolutely right. We're once bitten, twice shy kind of thing with our new nurses, and they're told not to, rush to give the narcotics, but unless that nurse has had that surgery, it's very hard to relate to what the level of pain is,
Right.
All right. Well, I think we have done post-op assessment 101.
I think we've covered the 101.
I think so. All right. Well,
excellent. This has been a good conversation.
It's been a great conversation.
Yeah.
Like you said, I did the teaching, you did the stories. What a great combination, right?
Tag team that one. Awesome. Well, Caroline, this has been so much fun. I'm so glad we got to do this together today.
You too. And until next time, thanks for listening, everyone. And we will see you all soon.
We look forward to connecting with you on our next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org.
We'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You'll receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners.
We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #MedSurgMoments to your post. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, I'm Caroline.
I'm Alissa, and always remember, Med Surg Moments is a moment in our lives, a moment in our med surg careers that makes a huge difference.